Good morning, everyone. This is Leslie. Welcome to today's webinar. Today we have Kathy Mueller. She is the program manager for the Health Homes program with the Department of Social Services. If you have any questions during the presentation, you feel free to use the Q&A, or you can unmute your line and ask us directly. Go ahead and get started, Kathy.
Good morning, this is Kathy. I'm very excited to share this program with you today. I think when we implemented it 4 years ago, there was a lot of confusion on how these two programs could work together. So after we're into our 4th year and really want to work on integrating this into some of the other services that we're providing throughout the state. So I'm going to share with you a little bit about this, if you want to go to the next slide. And why we want to do health homes in the state of South Dakota. And I'm really excited to share towards the end today some of the successes we've had. So next slide. So what is a health home? For a health home is really a group or a team that works on the medical needs of a recipient. And it's out of the Affordable Care Act. It was an option that we chose to participate in. It's really focused on providing 6 core services that we'll talk through later in this presentation. But what we found is that the design of this program really helps affect change for those recipients who have high cost and high needs through our Medicaid program. Next slide. And so this gives you just an example or shows you the actual enrollment in South Dakota Medicaid basis versus the cost of those recipients. So as you'll see, children are a large percentage of our population, but only a small percentage of our spend. And if you take a look at the blind and disabled adults, you'll show that there's 15% compared to the 37%. And what we found overall in South Dakota Medicaid is that about 5% of our population drives 53% of the costs. Next slide. So let's talk a little bit about how the health home program is made up. Next slide. So there are 2 types of health homes, one that's really focused on the primary care provider and the other that's focused on behavioral health. And we have both of them actively working in the state right now and working very closely together. So let's start with the primary care model. So under this model, there's a designated provider, and that designated provider could be a primary care physician, a PA, or advanced practice nurse. And then what makes up the health home is all of the designated providers within a federally qualified healthcare center, rural health clinic, a clinic group practice, or an Indian Health Service unit. And then what that designated provider does is creates a team of people, not necessarily internal to their office structure, but even externally. So it could be the waiver provider or other services that overlap with your, but it's really what that recipient needs. So in some instances, it could be a pharmacist. In some instances, it could be a dietitian. And it's just really dependent on what that provider or what that recipient needs. The other model is the behavioral health model that we currently use only the community mental health centers to implement. And so 9 of our 11 community health centers participate in this program. And in those instances, it's a similar model. They typically team up with a primary care provider that recipient is already seeing, and other services as needed, or other care team members as needed, in order to ensure that all of the recipient's needs are met. Next slide. And so let's talk about who health homes serve. And I want to spend a little bit of time on this because I want you to see how the conditions that we serve through this program are not necessarily the items or conditions that make individuals eligible for your program. So ours is really focused on chronic or behavioral health conditions. So it's really any Medicaid recipient. They don't have to be Medicaid only. They can be dual eligible for Medicare and Medicaid. They can be on a waiver program. They can be in a long-term care facility. But in order to meet the criteria of this program, they have to have either 2 of the chronic conditions listed there, or 1 of those chronic conditions and 1 of the at-risk conditions, or on its own, 1 severe mental illness or emotional disturbance will make them eligible. And the way that we determine them eligible is that we take the past 15 months worth of claims history, and we have a vendor who runs through those claims to look for the ICD-10 codes associated with these conditions, and that then makes them eligible. And so if they, again, have 2 ICD-10 codes in the chronic conditions, they'll be eligible, or if they have 1 in the chronic and 1 in the at-risk, they'll be eligible, and then also if they have just 1 of the severe mental illness or emotional disturbance, they'll be eligible. And then what we do is we tier them, tiers 1 through 4. And so you take that group that's eligible and we run that, or the vendor runs them through an algorithm called the Chronic Illness and Disability Payment System. And that tiers them, tier 1 through 4, based on their current needs and their future risk of cost to South Dakota Medicaid. And from there, then we send them a letter indicating that they're eligible. Now we handle those tier 1s differently than we handle tiers 2 through 4. And it's based on the fact that we don't have enough capacity throughout the state to manage 63,000 people, which has been to date the amount of individuals made eligible for this program. But half of those are tier 1. So the way that a tier 1 looks is that they have the conditions, but they're normal. So they might have diabetes, but their hemoglobin A1C is less than 8. Their asthma is controlled, they're on their medications. And so actually putting them in this program may over manage those individuals. And so for those individuals, we send them a letter that says, you're eligible for this program and you're welcome to join, but you need to call us. So essentially they're out until they say they're in. The way that we manage tier 2 through 4 though is they are in until they say they're out. So again, I'm going to take that in 2 different directions. So the vendor that does all of the work for us also looks through all those claims to see if they can find a provider that they are have an ongoing relationship with. We call that a continuity of care provider. If the recipient is tier 2 through 4 and they have a continuity of care provider, we will just automatically put them in the program, and they have about 35 to 40 days to remove themselves from the program. Otherwise, they'll become part of the program. If they do not have a continuity of care provider, we still send them a letter and ask them to pick one within a certain date. Next slide. So that was a lot of information that was not on the slide that I actually talked about. So our current provider capacity is we have 120 health homes that serve 124 locations, and you can see the breakdown of those locations, not next actual locations there, but the types. We have all 11 Indian Health Service units that participate. The extra 4 locations typically land with the community mental health centers. We have a number of them that have locations outside of their actual practice. We have around 600 designated providers. That fluctuates, and it's probably higher now. We had Ortonville, Minnesota start on July 1, and on October 1 we will have 6 new clinics starting, which significantly increases our capacity. 3 of them are regional health clinics, 1 in Rapid, 1 in Deadwood, and 1 in Custer. And then we also have the Mobridge Regional Clinic starting, and the West River Clinic in McLaughlin, and the West Dakota Clinic in Timberlake. So all of between those 6 clinics, we were able to attribute about 300 people that weren't previously being seen under this program. Next slide. So here, as of August 29th, we pick 1 day every month to just measure our participation level. We happen to go down a little bit this month, but again, with our new attributions, we should be right back up between that 5,700 and 6,000 level next month. So we've broken it down here by type by tier. You can see that tier 1 is very small, and that's intentional. And then our tier 2s, and then it just kind of goes down from there, with a total of about 5,700 people participating. Next slide. So I want to talk through the core services, and this is where I want you to think about how these services that the medical community or behavioral health community is providing can interact with the services that you're providing. Next slide. So there are 6 core services. They're required by CMS to be provided to each recipient at the level that is appropriate to them. Now, CMS requires the actual core services, but we define them as we felt we needed to. And so health homes are paid still for all of the services that they provide in the method that they were previously provided. So if they were paid a daily rate, they still get that daily rate. If they were paid a per diem, they still get that per diem. But we also, on top of that, pay on a quarterly basis a retrospective monthly PMPM. Now that's kind of a hard concept to wrap your head around, so I'm going to spend a little more time talking about that. So in the room I have 3 people. I'm going to say that all 3 of these people were on my health home for all 3 months. So let's take a quarter. January, February, March is a quarter. And then in April, the health home has to go in and say, did Leslie and
Kathy and
Michelle get, I'm sorry. So I got myself into something I didn't quite know who the people were. So did all the people in the room get a core service? And if they did, and they were in all 3 months, and let's say you're a tier 2, I would get after the fact, I would get $29 for each month that you were in the health home. Now, if you didn't provide a core service, you would not get that per member per month.
Okay.
And so they're required at a minimum to provide one of the core services to each recipient. And it should be an action that actually engages the recipient, not just a team talking about them.
Sure.
Next slide. So here's the list of the core services. Some of them may seem a little bit familiar to you based on the program that you already conduct. But I'm going to go through and walk through some of how we define them. Sorry, I spit on Leslie's computer accidentally. Next slide. So for comprehensive care management, we look at that as the development of the individualized care plan. Now, if a person was on a waiver, we would see integrating that care plan, or I'm not sure what you call it.
We do have a care plan. Mm-hmm.
Care plan into the care plan that's developed by the medical community, where your group might be focusing how to keep them at home and services that they need to have that. Our team would be focused on their medical conditions and helping them establish goals. And so I think they can very nicely dovetail together. Mm-hmm. Then the next item is care coordination. We see that as taking the plan that was developed and working to implement that. So if they need referrals to see specialists in the medical community, the team through the health home would help them get those referrals done. They would also make sure they have the correct supports and services through you. I mean, again, it's making you all part of one team rather than 2 separate teams. Mm-hmm. The third one is health promotion, and that's really working to help promote their healthy lifestyles. So, for example, if an individual has obesity, it's getting them connected with a dietitian. If they need to quit smoking, it's getting them referred on to the South Dakota Quit Line. It's making sure they have all their immunizations. I mean, I think a lot of things fit under this. Mm-hmm. If they need help to try to self-manage themselves, making sure that they get referred to the Better Choices, Better Health program through the Department of Health.
They're getting preventive care.
Yeah, that they're getting all of their appointments,
sure,
dental, and all of that stuff. So that's really what health promotion is. Next slide. This next core service is really probably the most challenging core service that our providers do. And it's because they oftentimes aren't aware that their recipient was in an ER or had a hospital stay. And so sometimes having that extra person who may be knowledgeable about that as part of the team, so for example, a waiver manager might help them actually know that their recipient was in one of these stays. Mm-hmm. And so this requirement is that if they have an ER visit or a hospital stay, that they follow up within 72 hours to talk about, were you able to get your medication? Do you know how to take your medications? Do you know when your follow-up appointment is? Well, first, do you have a follow-up appointment? Do you have a way to get to your follow-up appointment? And did you understand the discharge plan that was given to you? So really helping that recipient adjust to being at home and making sure they have everything they need. The next core services is really, I think, where our programs dovetail pretty well together. And it's making sure that the recipient and family support services to help them reduce barriers to their care coordination, increase their skills and ability to manage their own care. So I think what's the other waiver program?
There's the HOPE waiver, which is under the LTSS division, and then the ADLS waiver, which is with Jennifer Guther and her 2 care coordinators, I believe, are on the call today.
Okay, so I think where we're working to have a person manage themselves at home, this is a good core service.
Absolutely.
And then this last one is referral to other community and social support services. So typically these care coordinators have a pretty large list of services. And so looking at the care plan, if the individual is unable to meet their food needs, making sure that they know where they can go to get food, legal needs, it really encompasses all those things. Transportation is a big one that our care coordinators do, helping them get transportation to appointments locally, to appointments outside of their community, using NEMT through the Department of Social Services. But really it's to help them get access or gain access to the community and support services locally. Mm-hmm. Next slide. So this talks a little bit about our requirements, if you want on the next slide. So again, they are required to report every quarter, and the quarters are set. It's not the quarter that the recipient was in the Health Home program. So for example, January through March, they are required to then do that. Did I provide a core service by the end of April? And then so you can see that's just the reporting schedule there. Next slide. We also have a lot of outcome measurements, and they're reported on a biannual basis. Our outcome measures focus on really three parts: clinical outcomes, experience of care or satisfaction, and then quality of care. And they report electronically to us every 6 months. And again, you have that 6-month period, and it's standard for everyone regardless of whether they came on the program 3 months into it or 4 months into it. And if they provide a core service, they have to report those outcome measures. So I wanted to share with you that over the 4 years, kind of our experience in this program. And so this is just looking at fiscal year 2016. You can see that the average age of our population is 43, 61% is female, 69% of the individuals in our program are age blind and disabled, with an average number of conditions of 4.8. So if you compare that to the average Medicaid population, they have about 1.1, where this population has a significantly higher 4.8.
Yeah.
I'm going to have to get close here to read. So I apologize that this can be a little bit small. Leslie has the full PowerPoint.
I did send it out.
And so hopefully you can see it. So these are some of the outcome measures that we have. There's about, the first few are actually a comparison between 2014 and fiscal year 2016. And then there'll be a couple where we're just comparing 2 periods within fiscal year 2016, because we redid a lot of the measures because they weren't working, and so that would be our baseline. So the first one we found in our first fiscal analysis in fiscal year 2015, we finally had enough data where we felt like we could do something with it. We found that there was a reduction of 1.2 claims per person per month, with a 14% reduction in the average number of monthly claims for inpatient, outpatient, and prescriptions. The next one of the requirements is that each recipient in the program has a depression screening. And over the course of those 2-3 fiscal years, we saw a 40% increase in the recipients screened for clinical depression. We found a 6% increase in the number of people visiting their primary care provider in the last 6 months. So what we're seeing is people less ER, less hospital, more primary care, which is really kind of the direction you want it to go. The last one on that first line is we had a 59% increase in the number of counseling sessions with recipients and families to adopt healthy behaviors associated with their disease risk factors. Then on the bottom line, we had a 38% increase in the number of recipients screened for substance abuse. Again, the recipients are required to have this substance abuse screening, and so that percent of an increase over that amount of time we feel really good about. We also, so this next measure is a community mental health center one only, and we saw a 24% increase in medication adherence for prescriptions filled at least 85% of the time for individuals with severe mental illness, which again, that's a huge increase. This next one, because this is one of our focuses, that 72-hour discharge, we have a 39% increase in the number of recipients who received a follow-up contact within 72 hours of discharge. So we feel really good about that one as well.
Yeah.
Then these last two are between period 5 and period 6 of fiscal year 2016. 49% increase in the number of recipients whose summary of care was transferred electronically, and a 17% increase in the number of recipients with an active care plan.
That's pretty amazing numbers there.
Next slide. So not only are we seeing that people have improved health through the program, but we're seeing that we're avoiding a pretty significant number of dollars for the Medicaid program. So if we looked at the analysis in a couple different ways. The first one is, and this is reflecting, it's a match study. So we took individuals who were in the Health Home program and matched them with an individual that looked like them that was not participating. And so had we not implemented the program, it would have been the red line and then the green dotted line. But those individuals who were in the Health Home program then became that orange dotted line. And so the total sum of that is between $4.2 and $5.6 million.
Yeah, that's pretty significant.
Yeah. And so again, here you see that our inpatient costs are down. I'm sorry. Between 2013, when we implemented it in 2016, the number of inpatient visits dropped almost 20%, and for the top 5%, inpatient visits dropped by 9%. Emergency room visits over the course of this time decreased 25% for the entire Health Home population. And again, this just reiterates our 6% increase in the people visiting their primary care provider, and then the orange box summarizes the actual savings, the 4.2 to 5.6 million annually.
It's just unbelievable.
And so the final slide is a success story that we've had, and this is just one that we like to focus on because it's very dramatic, but we have several others that we could also share. So for this particular recipient, it was a 50-year-old recipient and actually enrolled in a community mental health center Health Home program since December of 2013. The starting weight for this recipient was 245 pounds with a BMI of 44.7. The recipient is now down to 129 pounds with a BMI of 23.3. She makes all of her dental and eye appointments as well as her yearly wellness exams. She's reduced her cholesterol through her weight loss to the point where they're able to stop one of the medications. And she significantly reduced her smoking and is working on quitting.
That's pretty awesome.
Yeah. So that really concludes what I have to share with you today, but I would be happy to take any questions you might have about the program, what it does, and how we can work together.
While we wait to see if anybody has some questions in the Q&A, I had a question. Back when you were talking about the tier 2 through 4, where they're just in the program unless they choose not to be, what would be the reason why somebody would choose not to be? Is it just they don't want that much oversight, do you think?
For some of them, if you are a dual eligible, so you're eligible for both Medicare and Medicaid, they don't require referrals now. They're not required to be in any sort of a management program, and so they don't want to have the referral process.
Gotcha.
Is a lot of it. But yeah, sometimes people don't understand the program well. They think it's home health, and they say, I'm too young, I don't need home health. And despite our ability to try to explain that it's not that
in the home.
Yeah. Some people just can't wrap their minds around that.
Skip over it.
Around, yeah.
Don't ask more questions and
Right.
just say no.
Sure.
Yeah. We do have a couple questions here. So the first question, if someone opted out of Health Homes prior, how do they become engaged in the program now?
It's as simple as picking the provider that's in the Health Home program and submitting a form with their signature on it.
Okay. And how do we make referrals to this program?
First, we would want to see if they're eligible, and they would just send them to me.
Okay.
And so, Kathy Mueller, you can email me securely. Well, you probably don't if you're part of the state.
I'll send out Kathy's information after the webinar today, so all of you have it handy. And she is in the Outlook calendar with the Department of Social Services, though. The next question is, what is the expectation of LTSS if we do have a consumer enrolled in the Health Home program? I guess my answer to that, and I think Beth is on if you want to add anything, but my assumption is that we would expect our LTSS staff to encourage the person to agree to become a part of the health home. I think it's as simple as that. You know,
And
maybe
then be
help
part
it,
of the team.
and maybe even be part of the team. Sure.
No, not maybe.
Not maybe. Be part of the
They
team.
need to
Gotcha.
be part of the team.
And being part of the team, what is that? I mean, is it
Well, I think it's
mainly through email? It's not like.
Well, it could be by phone call. The health home may want to, and it would be exchanging information
Sure.
about the recipient.
Sure. Okay.
And it could be different for each. I can't speak for the health home and what they would want
Sure.
their waiver person to be involved in.
I'm sure it depends on that. It depends on the person and what their needs are and how involved we are as far as providing services. But yeah, I think another thing would be to simply help them understand what the program is. And so that's part of the reason that we wanted to do this today, is so that all of you understood what the program is, so that you can help steer that person into becoming a part of the program. And then
we get the notifications when they're hospitalized and whatnot, so making sure they contact the health home provider.
We do, because that's the other thing I was going to share with Kathy, is that we, all of our LTSS staff have access to
the
Notify system, and so they would be able to share that information and know it quicker than maybe other providers would.
And some of ours do as well, but it's not consistently implemented throughout the groups. Not all of them are a point of care member, which allows them to have it for free, so there is an extra cost for them.
Yeah, there is an extra cost. Next question, it says if the SW95 shows that it qualifies for health home with a date, does that mean that they are already enrolled and using it, or just that they qualify?
Typically, that means that they qualify. What you would have to also do is look at the SW96 IPCP screen to see if they have a provider on that panel. Or if you contact using the new eligibility online portal through DSS, it should tell you that who their health home provider is. But qualifying for health home and being in a health home are not the same thing. They actually have to have a provider listed to be considered in a health home.
In the health home.
Yeah.
But that does then, what Barbara's asking here, is it would at least indicate to them that they qualify for it.
Right.
And then if they can't find out, or if they do find out that they're not participating, then they can follow up during their visits and encourage that person to do it. And then the next question, are we going to get access to SW96? I don't know the answer to that, but I can follow up.
Probably not.
Yeah.
But honestly, you can find the same information through the new provider online portal.
Okay, so what I'll try to do then is get more information about that and send that out along with Kathy's information.
And what you need to have in order to get that is you need to request access to the portal through Lori Lawson's group. And then from there, they'll give you access, and there are several roles that you can play. And there can be a state administrator role or a provider administrator role that gives access to the different functionality. And I can
send me something.
Yeah, or I can have Lori. We'll see what makes most sense. But you have to have the NPI. Does everybody have an NPI? Billing NPI?
Not our staff.
Okay. But you should be able to get state access.
Yeah, somehow.
So that would just be, let me talk with Sarah about that.
We will follow up on that, and I'll get some information out to you as soon as we can get that figured out.
But then the other way is to give them query access to the IPCP screen.
Right, whichever way is maybe the simpler, easiest. Next question, is there a full list we can access of all the health home providers?
Yes, that's on our website. Did I list the website anywhere in the presentation?
I don't think so. Where do you go?
It's possible I did.
I don't remember seeing it necessarily.
I don't either.
So I'll add that in. I'll send Kathy's information out today along with a link to the website.
Right, and we have our own web page.
Sure, health homes. And then I will follow up with the other question and see if we can figure out a way for you guys to get access to something to determine whether somebody is qualifying or participating.
Anything else?
Any other questions?
And if you have anything more, don't hesitate to ask Leslie, and Leslie knows how to get a hold of me.
Yep. All right. Thank you, everybody. There's a thank you for the helpful information,
You are
Kathy.
welcome.
We really appreciate you coming today and,
Yeah.
and sharing this information. I hope all of you have a great day, and the recording will be out on the internet as soon as possible. Thank you.